hello, everyone. I'm delighted to welcome you to our second installment of our Best Practice webinar series, Best Practices for Device Selection, Logistics, and Support for RPM. My name is Patrick Kelly, and I serve as Vice President of Client Success here at Validic, and I will be your moderator for today's event. So today we're going to be walking through how healthcare organizations can get their patients easily enrolled, onboarded, and supported during the setup of their condition management program. Our conversation will include two short presentations from Brian Carter and Mike Braham, and then we'll move into a panel discussion and audience Q&A. Now, before I pass it off to Brian and Mike for their part, we'll do just a couple housekeeping items to note. First, this webinar is being recorded and will be available on demand within 48 hours after the event. So just keep an eye out for an email with that recording. Second, we do have a lot of time set aside at the end to answer questions from the audience. So please do submit those questions in the Q&A box at the bottom of your screen. We'll get to as many of those questions as we can. And this really is an excellent opportunity for you to get Brian and Mike's thoughts on what matters most to you. I know in our previous webinar, in our first installment, we got a number of great questions and really good participation that led to, I thought, a very thoughtful and insightful conversation. So we're depending on all of you to carry that torch during today's presentation. And finally, as part of our best practice webinar series, there will be two more webinars following today's presentation. We do hope you join us on December 1st, where we will be joined by Humana, Providence, and Ironbow Technologies. That's a great lineup to discuss how to strategically define and evaluate ROI in an RPM program and sharing best practices for operationalizing an RPM program to achieve sustainable results when you hit scale. So make sure you are joining us for those. I think we'll drop the registration link in the chat box during this presentation. So please make sure you take a moment and register for those webinars. So for those of you who are returning to our Validic webinars, you know that we always like to start every presentation with our mission statement. And it not only grounds the work that we do, but I think in this case, it serves as an excellent foundation for our entire webinar series. As we continue to dive into how RPM programs and the data captured within them must be tailored to meet the patient or member where they are. So, when we talk about our aim to improve the quality of life by building technology that makes personal data actionable, we know that capturing this data and making it easy to capture is the first step in making this data work for everyone. And to frame our conversation, I thought this slide was a great entry point into our discussion today. And that for all of you on the line, I don't think it's going to come as much surprise that chronic condition management is one of the top challenges facing our healthcare system today. As you can see on the slide, 60% of Americans have at least one chronic condition, and that's a number we fully expect to rise over the next several years. As you can see that Americans, we are getting older and more individuals are entering in that 65 years and older age bracket more and more every single day. And when you couple that with last year, how the pandemic really completely shifted patients' expectations and outlook on virtual care as they had to embrace new digital tools. Actually, a survey by Fierce Healthcare found that 4 in 10 patients started using a new device or a new app to help manage their chronic condition. And of those, 90% of the individuals who started using a new device or new app rated that experience as good or excellent, and most importantly, wanted to continue to use them, which I think is good news for those organizations rolling out an RPM program or looking to roll out an RPM program. However, the challenge still exists that patient populations, there are still patient populations who are not as tech savvy and need more assistance in chronic condition management programs. And healthcare organizations are challenged with how to serve that broad spectrum of patients. And so that's exactly what we're going to be talking about today. We're going to be sharing industry advice to help your organization master those easy to overcome challenges and scale your RPM program. We're going to talk through best practices for device selection, fulfillment models, logistics, and support. And then finally, we'll offer some real-world examples and lessons learned to support diverse populations of patients with different technical acuity, socioeconomic needs, or condition severity. So with that, we'd like to welcome in our speakers. We have two excellent speakers with us today. First, on the right-hand side of your screen and the video up at the top, we have Mike Braham. At Trapollo, Mike is responsible for profit and loss performance and leading all aspects of strategy and execution of the Trapollo business plan. He retains a unique blend of strategic and operational experience in healthcare, telecommunications, and crisis management. Mike formerly led Magellan Health's federal division, and before his leadership role at Magellan Health, Mike served as Aetna's Chief of Staff, Head of Strategy and Innovation, and Head of Member Engagement and Digital Assets for Aetna's $8 billion Medicare division. So Mike, it's an honor to have you. Thank you so much for joining us today.
Thank you. Thanks for the honor.
Absolutely. And next, in the middle of your screen, also at the top, is Brian Carter as Validic's Chief Operating Officer. Brian provides executive leadership for Validic's product strategy, client enablement, facilities, human resources, and marketing. Prior to joining Validic, Brian was the General Manager of Population Health Management at Cerner Corporation. And he has more than 20 years of experience in healthcare IT and data. Brian, thank you so much for joining us today.
Hello.
So thank you all. We're looking forward to a great conversation. And with that, Brian, I will pass it off to you to begin the discussion.
All right. Thanks, Pat. I'm going to try to keep my slide portion here pretty brief, cover a couple topics really quickly, and make sure we leave a lot of room for Mike to share a lot of the things they've learned over at Trapollo, as well as plenty of time for questions. That's my favorite part of this series. The last session we had, if a lot of you had joined the last one, you know that we got lots of really good questions. That's so much more interesting, I think, for everybody listening today, as well as, frankly, more interesting for us to have a conversation than to just speak to the slides that we've prepared. But if we want to go ahead and go to the next slide here, for those of you that did join the last session, this will be a familiar picture to you. And it's really trying to tell the story of the idea that there is a spectrum of different needs for different parts of a population that we're trying to roll digital health solutions out to. And it can be a spectrum both on the providers, the care professionals, and that's what we spent a lot more time talking about in the last webinar. So, you know, how do I get something ready quickly that providers can just jump into and start using? But then over time, how do I create an experience that's much more deeply integrated into the clinical systems providers are already using? So this time we're going to talk a lot more about the patient or members experience. And so if we go to the next slide, you know, similarly, there really is a spectrum. You know, on the one end, excuse me, those that know Validic best know that we kind of got our start as very much a BYOD, bring your own device type of organization. We think we have the largest ecosystem of supported devices available in one platform, 530 plus today. And that is a great solution for a good portion of your population. But then there's other people where a fully provisioned, tightly managed kit that's just ready to go out of the box is going to be a better solution. And then there's this whole world that lives in between. And I think one of the things that Mike and I would want you to take away today is it's not this Boolean choice of, do you get a full kit or do you bring your own everything? There are a lot of different options in between. So if we go to the next slide, a way, and the way that I like to think about this is really, we've all seen the population pyramid before. Anybody that anybody that's ever studied population health management 101 has seen this pyramid where at the top you have your most acute 5%, 10%, depending on who's drawing the pyramid, that's driving the bulk of your spend. And then at the bottom, you have your worried well, or your folks that maybe just recently got diagnosed with a chronic condition. They're not at that high acuity level yet, but if we can help them learn more about their disease process early, they could reverse it, or they could at least manage the exacerbations of those. If we layer onto it then some context about the individual. So even inside that high acuity population, you've got folks that have access to more resources, maybe access to somebody in their family that can help them with technology. And then you have other folks that maybe are trying to do this more on their own, may not have access to the same resources, may not have a high level of technical skill. As you think about the programs that you're rolling out, really understanding how different programs and even individuals inside those programs map to this picture, you can really start to get a little bit more refined strategy that will let you scale to a lot more people while not either trying to deploy a solution that doesn't work for a lot of folks or blowing the bank trying to provide a higher cost solution for people that may not need it. So if we go to the next slide, let's start really quickly, and I'm not going to spend too much time on this self-setup process because that's what Validic's done for a while. So I think a lot of you already know about this part, but our Validic Impact solution, when we first released it, it really was based on a bring your own device type of model. And if we click to the next slide, the way that worked was the provider would enroll a patient in a program. Maybe in this case, we see a diabetes virtual care program. And then if we click the next slide, the patient, go ahead and go to one more, looking for the one with the iPhone on it. There we go. The patient then receives an email that says, hey, we've invited you to join this program, download this mobile app, sign up for it, and then we're going to walk you through how to connect the device that you have. In this case, we see a Freestyle Lite from Abbott that we're connecting. And this is an approach down at that base part of the pyramid that we saw that can really let you reach a segment of your population that perhaps hasn't risen to the level of acuity to either use RPM reimbursement codes, or if you're a health plan, to justify purchasing those devices and providing them to the patient. And this is really where we got our start. And we've seen really great success in scaling out lower acuity programs with this type of model. One of the challenges in this type of program is even when we're in a bring your own device type of scenario, sometimes, I want to use my phone and I have the tech skills to set it up, but I don't have that device. And so one of the things Mike's going to talk about a little bit more is what's that in between where you don't need a full kit sent out. I just need transactionally a glucose meter or a pulse oximeter or both, or a weight scale sent to the patient. So that's one model for a certain part of your population. Let's go to the next slide and talk a little bit more about folks that are a little bit higher up on that pyramid. Now we're talking about people where, good management versus poor management of a condition might be the difference between a $10,000 plus expense for an admission. Now we're talking about a program where it might make sense to create a little bit more curated experience that keeps more folks directly inside the lanes that we're looking for. So let's go ahead and click to the next slide. And go ahead and click to the first screen. So there we go. Just like before, when a clinician's enrolling a patient, we're still picking what conditions we're trying to manage, what types of data types we want to manage. But now with the click of an additional button, we can say, I want to provision a kit for this patient. And I'm going to work with that patient. We're going to figure out a PIN number that we want to set that kit up for the patient, and then just enter a shipping address for the patient. And then once we've done all of that behind the scenes, Validic's going to transmit all of that enrollment information and that requisition order to Trapollo. And Trapollo, if we click to the next slide, go ahead and one more, is going to package up a kit. And when the patient receives it, when they turn it on, it's all ready to go. It's set up with them as the user. It's got the devices that they need to use for that program already paired to that tablet. And the first time they turn it on, they're just asked to enter their PIN number, accept the terms of use, and they're off to the races. They just need to start using the devices, and that data starts flowing through to the Impact Remote Monitoring Kit. And if we go to the next slide, this is a picture, and Mike's got higher production quality pictures he'll show you in a minute, but I like to show this one because this is actually right here behind me. You can recognize that same credenza. That is a kit that Trapollo boxed up for me, sent it to me. You open it up, everything's neatly packaged, and once you unbox it and plug it in, go ahead and go to the next slide, it's there ready to use. And so that is the Validic Health Bridge experience right there on the tablet, reminding me of my goals, capturing the data, passing it over into the Impact solution for the care team to review. So when you think about, and so the first best practice that I'm going to hit here is when you think about a digital health solution or a remote monitoring solution, you know, we obviously think Validic does this the best, but regardless of whether you use Validic or not, a best practice that we think is really important is to identify a platform that's going to let you really tackle that variety of different use cases and fulfillment models and onboarding models, because there is not a one size fits everybody perfectly approach for every program that you're working with. And we think the same thing about you know, logistics and support and supply chain. That's why we think Trapollo is really cool. They have that same model of being able to you know, I think you might have the numbers better than me, but during the COVID-19 peak surges, you know, the supply chain for connected devices was so dry that Trapollo said, look, we're going to just find you pulse oximeters, even if they're not connected, and we're going to just get those into the hands of your patients or into the hands of your care team. You know, that's kind of a smaller transactional model all the way through to very curated program management. Having that same breadth of choices and a logistics partner and a tech support partner, we think is as critical as it is on the platform side. So I think that's the last of my slides. I'm going to hand it over to Mike.
Great, thank you. And hello, everybody. In case you don't know who Trapollo is an organization that's been around for about 11 years. We're located truly right off the runway here at Dulles Airport in Northern Virginia. We were purchased several years ago by Cox Communications, and so we're a part of the Cox family. And as a part of that, we're currently providing solutions that we'll be talking about here in all 50 states. So our opportunity to share some best practices is actually going to be pretty, I think, timely in how we're describing this to you today, but also to be able to look backwards for 11 years. There's been several highs and lows, and even some dynamics right now that we're needing to adapt post-COVID. And the things that we'll be sharing about today really is maybe how some organizations specifically now are going to try to get more involved with remote patient monitoring. They're going to try to maybe even grow some additional cases and how they're going to build their programs. And as we're really, I'll say, deploying our side of this, it's really to think about the quadruple aim. And if you haven't heard that expression before, it really is, how can we be a part of an organization like working here with Validic? How can we be able to improve outcomes? How can we help to drive down and minimize costs? How do we have a much better patient experience? And also, how can we help to make that experience of the clinician better? And as a part of that, that's really where I'll be highlighting, because so much of what we're trying to really undergird is going to be the cool and the sexy side often is with the really cool technology that we're talking about. But what we've really seen as driving a successful program, it is going to be the type of things that we're talking about here. It's going to be, how do we get this technology into someone's home? How do we treat them with a certain love and caring to which they'll enjoy the program and get the most use of it? And how do we part of that infrastructure to both get devices in and out of someone's home so that we can also improve that ROI for many of the organizations, whether they be payers or providers? And so when I'm talking about really the overall program goals and strategy, what I really would recommend is for everybody to really understand before they really get going is what are those measures of success? How are they going to be really judged internally to your all's organization? Getting that understood early is important, because what we often find is that the organizations or the part of the organization that purchases, let's say, or makes the buying decision for this technology is often different than the ones that are deploying it. And so from a program success measurement, to understand what are the different elements that we can help to provide in building a great program. And then workflow, gosh, to me, that should be saying workflow, workflow, workflow. Our experience over the bunches of years here is showing that if you don't pay attention to the workflow specifically and how this is going to work inside of that organization that's going to have this daily contact or however the measurement that is going to be part of that success measure, that will be a critical element with whether your program is going to succeed or not. And the patient selection, it's kind of interesting. I won't tell you how many, but I would say at times is embarrassing that what we've been able to do is providing, let's say, a patient that has COPD. Now, COPD being, a part of their breathing apparatus, you would be surprised how many kits that we get back that actually we cannot redeploy because they smell like smoke. So you wouldn't think that that's a big deal, but for us, is in the patient selection, if you're going to be putting out a program like that, you might want to know whether or not they're actually willing to be a part of the success measurements on their own side. Are they going to be fully compliant, or how and best can you select patients that will really benefit from this type of technology and solution? I just throw that out as one example, because that'll also then improve how you're going to be able to understand how to scale. Who are the patients? Where are they? What are their technology? What is their acuity in understanding how best to use some of these devices? And when it comes to scaling, where cost is often an element, to be able to start with one of these high acuity type of kits might be the way they want to go. But as you would build, as they become even more familiar with technology, or however you're going to want to bring in a much larger number across a large geography, it's going to be how are they going to be selected? How are they going to be brought in on the technology solutions? How are they going to add additional devices? And all that is things which you can work on in advance. So really it's the technology that's going to fit the patient. Personalizing these health kits is really important for you all to have your brand, your understanding, your extra care. And we're able to do all that by boxing and putting all of these things together, being sure that they all work before they even go out. And it helps to increase the adaptability or the adoption of these kits going forward. And so what we've seen in programs in the past has been that many organizations have used remote patient monitoring for really dealing with readmittance challenges and whatnot. So it might be in a patient's home for, let's say, 30, maybe 60 days. Getting that equipment back out, bringing it back up to speed so that it's technically, appropriate. It's going to be clean. It's going to be able to be reconditioned and brought back into the field again for an extra use. Some of that will stay intact for, let's say, those short period of times, but we're starting to see more and more that the program duration is going to be going further. And so as we're looking at some of the overall health benefits of being able to monitor longer, and to then working with that quadruple aim, how do we have better outcomes by longer engagement? We're going to be able to engage with that. And so if you'll go to the next slide, please. The part where, as we're building through some of these, it's really just to understand that, again, not sexy, but really important in how you're going to be able to develop your program and then to bring it in a full circle. We work on your behalf. We work on the behalf teamed with Validic so that we're going to be able to take the devices, we bring them in, we barcode them, we're able to scan them, know exactly where they are, which pieces go together. We then help by tracking them wherever they are along their journey, be able to know when they're going to be arriving at someone's home. We're able to pull all of this information together and share it. We want to be sure that before we send anything out, that it's been checked, and that the quality assurance is one of those key areas for us, and that we're also tied together with our system with the major shipping elements. And I'll just say right now, and we're all seeing this on the TV, so it's very topical, the shipping element of the supply chain and knowing the costs and the cost challenges that we're going to see over the next several months. Those are things which we're engaged with. We would work with you on that to understand on the timing or any challenges we would have. We help you with the patient setup. And then ultimately, as you're getting that patient up and running, and then also bringing them back in later on, how to get that kit out of someone's home is also one of the things which we help with. So the kit that you're seeing, the package that Brian was showing earlier, and I'll show you in just a second, it's designed for a two-way. So it'll show up in someone's home, and then they'll also be able to use that same box to bring it back. When they bring it back in, then we sanitize it, as I mentioned, and it goes in a turnkey environment. Let's go to the next one, please. So really, as I mentioned earlier, the full patient experience is where we want to focus. It starts with the care team. It's kind of neat. One of the things that I explain to my team quite regularly is we actually have the opportunity to give love each and every day. And what that really means is that when you're answering technical challenges or you're answering any other questions and you're working with patients, oftentimes it has to be not just answering a technical question, but it has to be done in a loving and caring way, because some of the seniors or someone that maybe is not as familiar with the technology, or just they're just not feeling well overall, and they're trying to deal with any kind of issues that they have. We need to build a team that's going to be able to treat your patients incredibly well. And that also goes with having consistent communication. It's going to be an opportunity for us to personalize and to be sure that these kits are easy. And as you're seeing there, the pictures, any of those can be customized for specific use that you would have. And that what we're able to do is to provide support and to put all of this in this, turnkey, as I mentioned a few times. It is because it's just not one size fits all, and it doesn't just always go out and come back. There is going to be greater opportunities as technology changes in the future to be able to use things that are both, let's say, FDA approved medical devices and then other type of sensors. So a lot of great things happening here going forward. Next slide. And as we kind of wrap up, it's really just to say, how can we help and team with Validic to come out and to help you all design a great program? We'll bring 11 years of experience into doing that. We want to be sure that the experience is outstanding for that patient and for the clinicians that are going to be using it, and that how we can ultimately build that full patient experience such that they also will be able to share that success with their caregivers and those that love them as well. So we're really excited and thankful to be working with Validic, and I turn it back over to you.
Great. Well, thank you, Mike and Brian. Really appreciate that. That was super informational. And so now we'll open it up to the audience. Please do submit your questions in the Q&A button at the bottom of your screen, or if you want to put them in the chat, we'll start cataloging them and answering those questions. But to start us off, Mike, one thing that you hit on, and I'd love for you to go into a bit more detail, because it's a question that we get frequently, is how do you select which patients are the best to enroll in these programs? You talked about a willingness. I thought that was really interesting. I'd love to hear more detail on that. And then what other qualifications do you typically look for those patients to best enroll in these programs?
I really want to share that we're working in direct support of that organization. It's really through the criteria where I mentioned to try to get an understanding of what is considered a success in the program. It could be some different type of measurements to which they're going to claim as going to be those key indicators for a successful program. And right now, just the ones that I was making mention, it is going to be their willingness to engage. If someone is not going to be compliant with any of the medications or any of the treatments or anything else, or even taking the readings, that's probably not going to be a success. It's also understanding where, as we go forward, are we going to be able to see folks in a rising risk profile, not just maybe someone that has a specific identified disease state, but especially when we're looking at comorbidities. And when you have more than one of physical is how it was typically thought of in the past. But what are some of the things which we can work on with Validic and with also the organization to look at the behavioral health side as well? How can we look at keeping that total patient healthy and progressing along through a program?
I'd add to that too,
Please.
and really to also pull one of the questions from the Q&A into this, defining how you're going to measure success for the program really helps inform some of those decisions. So, if we're looking at trying to manage readmissions versus trying to manage, maybe costly exacerbations for newly diagnosed patients, even figuring out which patients are the right patients to start with and which devices are, all of those things kind of flow from how you define success in the program. On a new program, what I tend to see is, one of two different paths. If it is a new program that's intended to really define how the organization is going to manage remote monitoring programs and whether they have the right processes and staff and workflow and things like that, we would look for a lot more operational type metrics as the initial success metrics. How many patients that we enroll in a program actually continue participating through whatever the tenure is that was designed for that program? How many providers invite more than one or two patients? A success measure that I know Pat and I spend a lot of time talking about with our clients is probably focus less on the number of providers you get to enroll a patient, because a lot of providers will try something once. If you find a provider that's invited 20 patients, that's a provider that's obviously seeing benefit from the program, because they're just not going to continue to enroll new people if they're not seeing benefit in the program.
Right.
I don't know, Mike, if you'd add anything more to that point.
No, I agree wholeheartedly.
Yeah, some great insights. We'll keep the questions coming in. We're getting some really good ones. Brian, you talked about identifying those patients. Let me know a little bit, what are the most common challenges that you see in scaling an RPM program? Either, I'd say both starting one and getting it off the ground. We always say that, a rocket uses 95% of its fuel to get 3 feet off the ground or 5 feet off the ground. I feel like RPM programs can be similar. So, what are the challenges there? And then what are the challenges you see in scaling that program particularly?
Yeah, I think, again, I would start by first kind of stratifying into two different types of getting started or scaling. Scaling very small comes with challenges that you don't still have when you're on the large end of scale, and then large end of scale has its own issues. So, the challenges that I typically see when a client is trying to start a program and they're starting very small is, all of those things that Mike just talked about, the processes and procedures to maintain inventory, to train people to create those kits, to train people and get certified to be able to sanitize and reuse clinical devices. If you're doing a program with 30 or 40 people, there's a lot of expense involved in doing that. And when you're looking at the unit economics and then looking at what you're totally spending for a very small number of patients, it's hard to do that math. And so, for financial reasons, looking at, okay, what is that actually going to look like when it gets to a level of scale is really critical. The second thing, when you're launching a small program, is I've seen organizations that will immediately jump to wanting to do a fully integrated, everything's in the EHR on day one. And it's really hard to get on the CIO's roadmap for an integration project when you say net patient impact, 30 patients. And that's some of what led to Validic creating the kind of rapid deployment version of Impact that lets you access it through a web portal. I don't think that a web portal is the right workflow for a provider for the long term, but if you're trying to do a pilot with 20 or 30 patients, that may be the only way you can start, because trying to get roadmapped for an integration project at that small scale is pretty challenging. Then there you have the flip side when you start to scale to very large programs and scaling those. And one of the biggest challenges I'll say on just the program design side, then would love for Mike to jump in on the logistical side, is clinical governance and defining what are the protocols that we're going to roll out, what are the parameters, where do we want these data to file into our legal medical records, et cetera, all of those things. When you now have hundreds or thousands of providers participating, anything that comes with that amount of scale obviously also comes with a lot of input and a lot of opinions. And that's where governance and slower incremental changes start to become really important tools in managing the mass of that type of program.
And Brian, thanks for teeing up part of that. As we're watching, again, kind of in the rearview mirror, I'll say I always have to ask people when they would make an assumption or they would make a declarative statement around how many patients or kind of what was their willingness or the adoption rate. Is that pre-COVID or post-COVID? Because what I about a year and a half ago, I guess right about April, when everything happened in 2020, I got asked about this by one of the magazines that was trying to find out about remote patient monitoring. And what we learned in the first 5 weeks of COVID really sped up what we thought was going to take another 5 years of the development of reimbursement models, willingness and adaptability to a patient that would, let's say, there was always thought, well, seniors will not adapt to technology. And the part that we really have learned along the way specifically is, especially where you have a remote patient monitoring that's, let's say, tied in with a telemedicine visit, or whether someone is truly just even using their own cell phone, it is that everyone has kind of come up on the technical adoption. Even my father, 89 years old, he was, ultimately using his cell phone to see some of his doctors. Myself, I don't mind sharing some of my medical history. I have had 4 major back surgeries in the last year, all of it during COVID. So I had to see a bunch of doctors in different ways. I didn't need some of the remote patient monitoring follow-up, but I had to do a lot on my cell phone. And as we're looking at the adaption there, is that as a program is going to be designed, you have to look at a couple of different sales cycles, you might say. It's the sales cycle to introduce this opportunity to an organization, whether it be a payer or a provider. After that decision might be made that we're going to go ahead with the program, you have to almost have a second sales cycle. How is that organization, and where can we support as well to get the providers themselves, the clinicians, to bring their patients into these programs? What is that selection criteria we talked about? We also need to see that the scaling side of this is often limited by a couple of things. What's the cost for that first year, total cost of ownership, and then looking over, let's say, a 3 or 5 year horizon, because again, as we get in scale, you'll get some of those efficiencies. But we're also finding with some of the challenges really with the providers themselves, the clinicians specifically, is that there's not, it is a very tight group right now. There's not a lot of extra folks. So what is the ratio for one clinician against the population of the patients that they can serve? So we try to work with them and understand, what are these ratios? Also help when do we need to order new equipment? Be able to understand when something is getting down low. We try to take the core competencies to which we're really good at, so that any organization does not have to do that too. And that we found that oftentimes the best customers that we have are actually those organizations that have tried to do it themselves and realize that, yes, it's not cool, it's not sexy, it's trying to get equipment in and out of a home and get it running, but that's the make it or break it. And that's the area which we can help the most.
Yeah, it's great. Like, I'm sure probably, I know we get a lot of questions just about the ratio and the number of care managers to number of patients in the program. Any advice, guidance, best practices that you've seen on this front?
not that I could say with uniformity. It's funny, we've been fortunate to work with some of the largest payers and providers. We've worked with some of the large, even specialty organizations that are only focusing on one disease state. Everyone wants to have something customized to meet their unique requirements. So I've seen different ratios depending on really how much personal relationship they want to have, to also augment what is the technology side of receiving, I'll say, readings and whatnot. And so it really is how much of the care that they're going to do beyond just the reading of different elements.
Yeah, absolutely. We've been getting a lot of questions just on devices themselves. I know what devices are being used in these programs. One of the questions we got, though, Mike, I'd love your thoughts, is what % of medical devices are potentially reusable versus the ones intended for single patient use, and kind of talk about that need. We've got another question about reusable supplies like diabetes strips. We'd love your insight on those two questions.
I want to be thoughtful before I just respond too quickly. When RPM first started, the cost of a kit was such, I'll say, a big number, that it made sense to do a lot of the turns, essentially, because they needed to amateurize, they needed to figure out how to get a really good ROI. What we've seen over the last 10 years specifically is the cost of those kits have come down pretty dramatically. The part that we're close to that inflection point right now, but it is at times, and we could foreseeably see this in the near future, the cost to leave something in place might make more sense than trying to ship it back and forth. The cost of shipping very well could outpace what is going to be the benefit that someone may get for leaving it in place. Having Validic have the opportunity to bring so many different devices into that ecosystem, I think that's part of the criteria, the selection of how the program would go. And so what we've been fortunate enough is, almost everything which we do primarily is self-installed. It's able to, if they need technical support, they can call in for it, but they're able to use that equipment essentially out of the box. And what we're trying to do now is to figure out, as one of those measurements, is where is the most cost advantageous point that will say, okay, it makes more sense to either bring a program in let's say 30 days because it's only being used for readmission avoidance, or if we're now going to talk about a longitudinal approach along a disease continuum, then maybe it makes more sense to leave it in the home much longer, or forever, really. So all of these are unique, and I wish there was one size fit all, but it's not.
Yeah. Brian, I don't know if you have any thoughts on that, or
No, I'm gonna just say ditto to, Mike has so much experience much more experience dealing with that than I do, that I'll just say ditto to that one. And the next question I saw in the chat here, Mickey asks, we tested asthma inhalers and saw 50% or so drop off pretty quickly, tips on reducing drop off rate. My biggest tip is provider engagement, and by provider, that's little p provider. That can be a physician, a care manager, a nurse, a social worker, a diabetes educator. I have clients that still have 75 to 80% engagement 90 days after patients are enrolled. And when there was a survey done of about 500 of those patients to just find out why and what are you doing. And over, patients in the survey response said, knowing that there is a care team member on the other side that A, is going to be there to help me if something happens, and B, is going to be following up with me if I suddenly fall off the radar, were both really big drivers. One is a little bit of a flavor of accountability, and the other is feeling like they're actually getting benefit out of continuing to participate in this program. And, you know, we all on this call, I assume, have bosses, and we've probably had bosses that have asked us to fill out status reports or update slide decks on a monthly basis. And guess which ones you keep updating? The ones that you feel like are creating some benefit. If you're just pushing information into a black hole and you don't feel like anybody's ever looking at it, and we're not making any decisions based off of it, you stop doing it as soon as you get busy. But if it's something that you're using to drive conversations inside your teams on an ongoing basis, you're going to keep those things updated. And those are the same things in our personal lives that really drive sustained engagement with things. A good follow-up, Mike, to something that you were talking about a minute ago. David asks, can you say more about monitoring senior populations and their tech adoption and avoidance? You hit on that a little bit, but maybe you can just kind of punch up the comments that you shared.
Sure. I'll say that of the $3.7 trillion that are spent every year in America on healthcare, the top three of the illnesses primarily being CHF, COPD, and diabetes. A majority of that really falls, I'll say, at 60 plus. So let's just round it up and say 65 plus. And with these folks that are in this particular population and in certain of the disease states, and so I'm a former Marine, or I'm a Marine, and with that, one of the things that is evident in let's say some of the studies which have gone on about behavioral change, and if you were to get injured, and let's say you were to lose a limb in battle, it's going to be easily understood that they might also have some behavioral challenges. So they might be able to have an impact from PTS and some of these things. I mention that because as we get more involved with, let's say, the population that all of a sudden might be receiving, today I'm fine at 249, but if I have a doctor's appointment at 4 o'clock and I learn that I now have a very serious illness, you immediately are going to have a shift in your thinking. You might have been unmotivated previously. You're now going to be very motivated typically to want to be engaged as much as you can in your own health, more so than if you were previous. What I'm finding right now is that the technology is such, especially why I mentioned pre or post COVID, is that if you look at something in 2019, they're going to say that seniors aren't going to go do this. What we've seen over this last year is you're seeing much more engagement. You're seeing that it's a couple of things. What is their willingness to try? I see them much more willing to try. What is their technical environment like? Do they have access to Wi-Fi, or do they just use the cellular networks and some of these other kind of things? We want to provide and help provide both the rural and urban underserved communities in such a way so that we're going to bring value, and that what we can do is to also engage them in such a way to encourage them. And so if you're looking at they're self-motivated now because I have this disease, and it might also become a comorbidity where they're going to have, again, too physical, but I'm also wanting to be sure I'm addressing their behavioral, their mental state. And how can we be encouragers? How can we show love? How can we provide that value in such a way so that they want to stay engaged with the program? And I think that's where the whole healthcare industry will ultimately get to, is how do we better engage patients when and where they want to be engaged, essentially, and to do it in a least obstructive way and bring more benefit. Yeah,
absolutely. Mike, I think that dovetails nicely into just, can you talk a little bit about the supporting, especially with the 65 and plus age bracket, we're naturally going to run into support issues, right? Onboarding, having trouble connecting a device, or a the cellular connection might go down. Talk to me a little bit about how Trapollo has been able to do that, of how you make those services available to organizations, and to make sure that those patients enrolled in the program are, if they run into any challenges, getting through those pretty quickly and easily.
Sure. We create relationships with cellular providers We work in ways that we can try to bring to, teaming with you all, teaming to bring a solution to that either payer or provider that wants to use this program, so that we can answer as many of those questions in advance. We can know whether connectivity is an issue if they're in a very rural environment, and that might even be part of that patient selection. If someone cannot reach their cellular provider, and or they don't have any Wi-Fi or any connection essentially in a very rural environment, or it could be downtown in an urban environment as well. Both rural and urbans are things which we try to work collectively with. We try to answer as many of those questions as a part of that program design, and then to be able to work through those issues. And then we hire specifically for those folks that I mentioned earlier, not just to be really technically astute, but having to be specific to say, how would you talk with your, let's say, grandfather? How would you talk with your grandmother? Would you be more caring? Would you provide love? Would you encourage them? Sometimes the only call that they get, or the only person they may talk to, is going to be you. And in that environment, we take that really important. We cherish that relationship, and thus we hire with those kind of things in mind.
Yeah, it truly is, because they are a lot of times those individuals are the face of the program, right? They have the device, they've talked to their doctor, but it's the person they're calling for the support is the interaction they're having, and they will associate that interaction with the program experience as a whole. So you're absolutely right. It's a massively important piece of it. So I really appreciate your insights on that. We got another question about just more about the BYOD structure with FDA approved devices, and specifically about billing for those CPT codes, the 99457, 99458. Brian, I'd love to know, just have you update the group and what we've seen with physicians being able to bill for those codes.
Yeah, definitely. And I will caveat that Validic does not provide legal advice, does not provide reimbursement advice. You definitely need to validate this with your own financial and billing teams. But generally speaking, in a BYOD type of program, you would look to not probably use the 99454 code for getting reimbursed for the full kit, the technology. Obviously, you're not purchasing those devices, but the 99457 for the time the clinician is spending interacting with an RPM program, generally that is still on the board for a BYOD type program. And so then you're really talking about how do you manage the costs associated with the program administration, the solution itself that you're using to capture these data, contrasted against your cost for the time spent that you're getting reimbursed for. And those reimbursement rates are geographically adjusted to account for the cost that's associated with the time spent. We've done some modeling, and we believe in a BYOD program that reimbursement code can help cover both the time and the subscription to the platform. And then when you start looking at provisioning devices and provisioning kits and all of the supporting technology, the technology supportive services, that's where you would really then look down into the 99454. But yeah, even if it's a BYOD device, if it is time spent for remote physiological monitoring, that is what that 99457 code is there for.
Great. Thank you. I think we have time for probably one more question. Thank you all so much for submitting so many great questions. I'll kind of expand on it a little bit more. The question is about the portion of patients who are able to self-install their kits. I think we can expand that to say, both Brian and Mike, from your experience, what is that breakdown of percentage that we've seen from patients who are just pure BYOD? They go out, they get their device, they're able to connect to their phone. Maybe they have their phone, but they just need the devices, and they can install or connect their devices to their tablet or phone. And then the third category, in a full kitted mode, all the devices are provided and already connected to a tablet that is provided to them. I'd love to know that breakdown and if we've seen success in any one particular area.
Mike, do you want to hit that one first?
Sure. I'll say for us, I wish I had more, I'll say a specific number. I'll say significantly, and I'll just say 80+%, if not even higher. It might even be 90% as I'm trying to think this through, are all self-installed. Because we package and we test and we pull everything together before it even leaves, then we're really helping to ensure when we're providing that package, it shows up at someone's door, that it's ready to go. We then provide that opportunity that if they need a little bit of extra support, they can do that over a phone. But I think there's a whole lot of different ways of looking at this going forward. There could be different technologies with, again, depending on where someone feels more comfortable, to have, let's say, a guided assistance. I loved what Brian showed earlier. It was a way just to show really easily how something could happen. And that's really where we see more. We really don't see very often anymore that a clinician has to go into the home. What we do find at times, depending on the organization that we're serving, if the patients, let's say, are coming into a clinic, they may leave with one like a kit. Some of the dialysis and other companies still use that kind of model because there's some maybe extra instruction. But when it comes to almost all of our packages that we're providing, it's going to someone's doorstep, and they're able to do it all themselves.
Great. Well, let me just say thank you both, Mike and Brian, for not only the presentations, but walking us through all of those answers and your insights into it. And thank you all for joining us and submitting so many great questions. I'll say you successfully carried the torch from our first webinar and set the bar pretty high for our third one. But thank you all so much for the questions. Mike, Brian, thank you for your time and participating today. Like I said, this webinar is being recorded. You will be emailed the link with the recording in the next 48, 72 hours. But thank you all so much for joining. I hope you have a great rest of your day, and we will hopefully see you all for our December 1st webinar. Thank you.
Stay well.
Thank you.
Thanks all.
Bye-bye.
Bye.